I want to invite to the stage our morning keynote speaker, Preston Simmons. We've known a long time. Many of you know him in a lot of capacities. He's the CEO of the Providence Health and Services Alaska region. Let's welcome him to the stage. Preston, thanks, sir. Here's this.
Okay. Thank you, DJ. And it's an absolute pleasure being here this morning and be able to kick off our day. So today, before I start, I want to give a kind of a public health announcement. So one of the things that Providence team believes in very much is the quadruple aim, and part of that is population health. So we're offering free flu shots out in the, there's about 200 shots. There's actually 199 because I was first to get one. I wanted to test it out. Juliet does a great job. It was absolutely painless, and there were no side effects. I always look and talk this way. So we're good this morning. So the way my presentation is set up for over the next 30 minutes is I'm going to talk a little bit about Providence, who we are. DJ asked me to do that. And then I'm going to depress you a little bit about talking about what's happening both on a national level and very much so here in Alaska in terms of some of the macroeconomic levers that are facing all of us. Then I'm going to talk about how Providence is addressing that in our vision for Healthcare 2.0 and how we're transitioning as an organization. We have a really cool beginning in Providence. There's not many organizations that could say that they started 176 years ago by 5 women. And we've grown to be the 3rd largest not-for-profit health system in the country since that time. The sisters moved to Vancouver in 1856 and started the first healthcare organization there, and then continued to expand out and serve communities throughout what is today 7 states. In Alaska, we've been here since 1902. The sisters came up and started serving the miners in the Nome Gold Rush in those days. And even at that time, very innovative programs were put in place in some of the first health insurance. In fact, they sold tickets to the miners and for a few dollars, and at any time during the year could be admitted to the hospital and have the best care at the time that was available. Our mission is that we are steadfast in serving all, especially the poor and vulnerable. Our vision is health for a better world. We have values of compassion, dignity, justice, excellence, and integrity, and very much believe in our promise of know me, care for me, and ease my way. And we also, on a national level, advocate that we believe that healthcare is a basic human right. And so we fight in our advocacy role very hard for that, to making sure that everybody has access to great services. This is our footprint. We span from Alaska to Texas. And Dr. Rod Hochman is our chief executive officer for the system, and we're very much physician-led as an organization. And one of the things that he says, we have to be big and small at the same time. And it's an advantage of having a partnership across a large organization because we're able to bring innovation at scale, but we're able to do that and work with our local communities and bring some of the best practices nationally to wherever we serve. Those are a few of our brands down on the lower right-hand corner that you can see. We really, in 2016, doubled in size to what we are today when the St. Joseph of Health system joined us. Across this footprint, we have about 119,000 caregivers. We have about 8,000 employed physicians and another 18,000 affiliated physicians, 51 hospitals, 829 clinics, and we offer everything from the most advanced quaternary care to supportive housing. We have a university in Great Falls in Montana, and we have a high school across from Disney Studios in Burbank and an international mission in Guatemala. So a very comprehensive system of care. Providence in the community here in Alaska, as I noted, it's whatever we do and generate in our economics go back into the community. Last year in 2018, one of the things we're most proud about is we did $84 million of community benefit here in Alaska, and it's broken out into the different categories there. It's the unfunded portion of Medicaid, so government programs does not count Medicare. It's free and discounted care for patients in need, so about $20 million in pure charity care. Community health grants and donations, and those go into programs like that you've heard recently around the supportive housing, where we partnered with Primera and Widmer and Rasmussen Foundation in Providence to give $15 million as part of a $40 million investment to end basically functional zero homelessness here in Alaska, in Anchorage, and other programs like Alaska Cares, which is part of our children's hospital that provides free care to children that are abused. And so in terms of a facility there, that is a community impact model. Education and research, it's important to build our workforce of the future, so partnerships with University of Alaska Anchorage and other institutions throughout the state. And then subsidized services, where we actually provide a service that is not, if it's not provided by Providence in Alaska, people have to go out of state for that. An unknown fact, actually, that we are also one of the largest taxpayers in Anchorage. We paid $25 million in payroll and property taxes last year, and only received about $39 million in tax exempt support through the programs. So what are the healthcare challenges in Alaska and elsewhere? And as we all know, the cost of healthcare is continuously rising and is at a breaking point. And that's what's causing both the national conversation as well as locally. It's now 18% of gross domestic product in this country. On the right side, the needs of the poor and vulnerable continue to grow. There's 500,000 homeless in 2018 across the country, and 4 out of the top 10 states are within the Providence footprint. And in here in Anchorage, our point-of-time count this last year, there's about 2,400 homeless approximately, of which 1,100 approximately are chronic homeless. And those are the ones that we're working on with our partners in the community of how to help eliminate that issue over time. We all know, especially acute here in Alaska, is behavioral and mental health issues and substance abuse. So that's a big one that we are trying to focus on with our partners in the community. And there's some great partnerships out there with ASHNA and the Mental Health Trust and South Central Foundation and others in the community, the city and Providence, trying to look at really from a systematic standpoint of what is the best system of care out there, what our gaps are, and where we need to make investments as a community to help solve that. About 14% of all Alaskans are still uninsured, according to the most recent data in this last year. And then McDowell Group just did a survey. It's a little bit lower, about 6% here in the Anchorage and Matsu areas, but that will start growing as people start dropping off health insurance in the years ahead. Our demographic issues are actually probably a little more acute than in many other areas. The shifting of the U.S. population is the baby boomers are now aging in at a very rapid rate. In fact, in Alaska, we have one of the fastest growing Medicare populations in the country. There are 108,000 Medicare enrollees now within the state, and that's up about 11,000 since last year. So going in that. On the right side of this diagram, it shows that as aging in and what's driving some of the cost of healthcare, it's an underlying principle, but as healthcare people age, their conditions become more chronic, those are more costly. So you can see here about 25% of the Medicare population accounts for 80% of the total spend. And that's going to continue to ratchet up. So what that demands us to do is think about systems of care in a different way of how we can partner together to serve the population in the right care setting at the right time, done in the right way. So it's actually moving from more of an acute-centric model and moving upstream and partnering more in the very much in the ambulatory and making sure that we have an excellent physician community that's well supported. The current also economic pictures. On the left side, this is the growth in real per capita national expenditures. Actually, with the advent of the ACA and leading up to that, we had some of the slowest growth per capita in this country. And it was due because of the shifting to value-based care in many portions of the country. In fact, it was at about a 1.1% growth rate. Since that time, because of some of the demographic shifts and actually growth into the Medicare population and others, and losing insurance, those costs per capita have started going up again. And so that's something we need to pay a lot of attention to. Kind of macro, the hydraulics of healthcare reimbursement. In the good old days, we used to take the profit margins that were made on the commercial side and cross-subsidize to our charity care components as institutions in healthcare and cover what was the deficit and the underfunding from government. What this slide demonstrates, and I can tell you the next period from 2014 to current is even worse, but Medicare and Medicaid don't cover cost of services, and employers and the community are demanding that payers do not increase premiums. And then that is what the payers' costs are revenues for healthcare, and so those are suppressed. So the math equation in terms of cross-subsidization doesn't work anymore. So that forces us as a community and a state of Alaska and others to really think about how healthcare should be delivered differently. And the only way, in the video at the beginning, it was talking about, and in terms of partnerships and how we work together to create the right solution. And I personally believe Alaska is probably best positioned and can have a vision of healthcare that is second to none in the country. Everyone else in the lower 48 has made a lot of mistakes, so we know it's worked. We need to make it Alaskan, bring it up here, and partner to create a better healthcare, what is a great healthcare system, and take that to the next level. I just want to give you a little bit of a concrete example of that shift in terms of sources of payer sources within, and this is Providence, Alaska Medical Center comparing 2013 to 2017. You can see as the expansion of governmental payers and coverage, our source of payer revenues there went from about 50% governmental up to 60%. Commercial went down as a percentage to 29%. And what that does is it shows that a larger proportion of what we do, and this is pretty similar of any hospital and probably more acute in some of the rural areas where most of the folks really rely on governmental sources of payment, and they're basically at a break even or starting to get into loss positions. So we really need to think through how we're going to help our rural partners in terms of their models of care. And I think there's some good examples around the country. But self-pay during that time went down because of the ACA expansion. But what we've seen in the last couple of years with catastrophic health plans and more out-of-pocket and people buying plans that really don't cover full service and actually going now without health insurance because the penalty isn't there anymore, that self-pay component in bad debt is going up astronomically in our system across the board. And I know that's happening here in Alaska as well, and that will continue to exacerbate. What that means is that becomes bad debt, and it's not, our receivables end up going down. Employer Benefit Health Survey, this is 2019 data. It shows that the premiums and deductibles are rising much faster than workers' wages. This is especially acute in Alaska, and I think is part of the reason why we've been in a recession for a while, is more and more of it's costlier for the cost of healthcare here, and more employers are trying to cover insurance for their employees, but it's becoming unaffordable, and it goes into that total wage, which then makes us non-competitive for recruiting the talent we need up here in Alaska. So that's another underlying macroeconomic factor that's happening. Insurance deductibles, I already talked about this. This is comparing 2010 to 17, but it's by different type of insurance product. This is for, on the right side, is employer-sponsored plans. If you're an individual in Alaska right now buying insurance on the exchange for a family, the deductible for the bronze plan is $12,700. And for most families, that becomes unaffordable, and you can't actually pay that deductible. So you're buying insurance only and then can't afford that throughout, and so that becomes problematic for us as well. Changes in the market. These just some amazing things happening nationally. Just this last week, the one in Walmart is one of the most amazing. So Walmart has about 1.5 million employees across America, and they have about 3,000 or 4,000 locations. They're in every community. They are now selling bundling. They're getting kind of into insurance, and they're bundling programs around medications, dental, drugs, and so forth, package pricing. They just opened their full healthcare clinic down in Dallas, Georgia, a 10,000-foot clinic that's full service, that also has virtual care. And they are offering through their Live Better You for $1 a day to any of their 1.5 million employees, one of 7 bachelor degrees, to train their workforce to go into these new programs and services that they're developing. And they're one of 7 baccalaureate degrees that go into healthcare, pharmacy, health information, terms of health management, clinical programs, et cetera. So that's another thing in terms of the disruption for healthcare. So as healthcare provider community, we need to be able to disrupt the disruptors and move quickly enough to create that value equation that the community and employers are demanding in Alaska and elsewhere that we serve. We'd all read about CVS and Aetna, what they're doing, Amazon and others getting into healthcare. Right now, mostly Amazon and Google are doing programs for their own employees, but those in virtual, and a lot of investment in that, but those are going to start expanding out into the community as well. So that's something we need to pay attention. We're at a tipping point. So how is Providence addressing these changes? Well, one of the things the sisters did about 7 or 8 years ago, as there's less sisters around, they turned the sponsorship out over to for the most part, to something called a public juridic person. And at that time, they wrote a document that was called the Hopes and Aspirations. And within that, there's a paragraph that says that leaders within Providence need to respond to the signs of the times. They don't need to be constrained by past practices, create new partnerships with aligned organizations in the community to create better health care systems, I'm paraphrasing here, but basically to create new programs and services with like-minded organizations to serve all within the communities. So we have taken that very much at heart, and what we're doing is we're deconstructing Providence and reconstructing it in a different way. And we are leading transformation of healthcare in this country. We're moving from what was an acute-centric organization to one that is healthcare 2.0 on the right, and we're moving here very fast. What is at the center of this is patients and consumers that are caregiver-enabled and digitally enabled with a system of care perspective and all the partnerships around that to serve the community no matter where an individual is, one person at a time, based on best practices. And when we define caregiver, it's everyone. It's our physicians that work with us, it's our employed individuals and so forth. Everybody is a caregiver within Providence. So a massive amount of innovation and investment in digital means and virtual means of doing that. And I'll talk about a couple of those in a minute. But the key is working with others in partnership. We're looking at what should be local, what should be regional, what should be on a national basis, and what should be global. And we're looking at best practices in each of those domains. Underlying this is the quadruple aim, and I've been a strong believer in this for a long time. There's 4 elements to this, and you probably all know these, but the way I define it is the patient experience of care, 4 pieces to that. It has to be around the highest quality, the highest safety, it has to have great access and best service. You only, as patients, when you go in, you really experience more of the service and access pieces and assume the others, but those have to be at the highest level. The second area is affordability. Healthcare has to be affordable to everyone. And so we need to redesign the systems to be able to do that, and how we reduce costs, reduce duplication within our systems of care so that we can bring that affordability and value to the community. Population health. So you're going to hear some more about that in, I think, one of the sessions later, but how do we work on the social determinants of health? The United States spends 2 to 1 on traditional medical care. Other industrialized countries with better outcomes spend 2 to 1 on the social determinants. So how do we work across and think about that? There's some things you'll hear about in population health, which is a social ecological model, where you look at actually at the interface of policy and built systems, and it's a public health model, and the systems of care that you provide in a community to really advance healthcare, and it's a great principle. And then the 4th area is care team well-being, and in that you have to have a great environment in which to practice medicine and healthcare. Because if you don't have healthy providers and clinicians and caregivers, you're not going to have good outcomes in your care. And no one of these 4 elements is more important than the other. You have to work on all of those. So this is by 2023, this is our system is going to be going through transforming to deliver the quadruple aim. And I'm going to talk a lot in a couple different slides. This next slide is basically which we took that one, sorry. More access to care across the system, best in nation clinical outcomes at lowest cost. I'm going to give an example of that. So we have 25,000 clinicians that are associated with us across, and we've created clinical program groups that we develop best practices within our system, and we then deploy those very rapidly. An example of that is within our women's and children's services, we virtually, while the rest of the country has gone up and had an increase, and you probably saw it, I think it was a New York Times article last year around mothers' mortality rates are going up in this country. Across 70,000 births last year, we virtually eliminated any deaths for moms in our system across all those deliveries. And that's because we took national best practices, we implemented those across all our 51 delivery centers in our institution and got that level of outcome. And so we have other states now contacting us as an example. We do that across all our clinical institutes, neurosciences, orthopedics, heart and vascular, women's, GI, et cetera, and really bring those clinicians together as physicians, understand best practices, understand variability in our system through a program called value-oriented architecture, and eliminate that variability to drive improvement. We also, healthcare is way behind the cost curve in terms of doing best practices around administrative structure. We're going to be pulling $1 billion out of our system this next year. We're looking at what are national best practices that Fortune 500 companies do around HR, so we're partnering with IBM. Revenue cycle, Accenture, some components of that, and Deloitte for ERP, which is Enterprise Resource Management. All this is done to create that value equation and provide better support to our physicians and caregivers at the site of service that they're doing. We've done huge investments in automation. I'll get into that in a minute. Population health, I talked about that, the social determinants. So I'll skip that slide. An example, so we partnered with the state under a CMS grant in our family residency clinic. We have a 36 physician residency clinic here. It's a pilot project around 5,000 Medicaid enrollees, and it's a medical home model where we're getting per member per month service to do care navigation outside the traditional clinic setting, where we're wrapping behavioral health, nutrition, pharmaceutical, et cetera. In the first 9 months of that, we just got the data, we reduced among ambulatory care sensitive conditions, which are conditions that someone should have never gone to an emergency department for if they were treated appropriately or had access in a clinical setting, by 18%. We also, not only was the cohort that we measured around those that in the ambulatory sensitive conditions, the entire cohort of the 5,000, we saw that reduction across. So that's thinking about how to do care in the right way, getting the right enablers in place and supporting our physicians and clinicians to do care in the right way, which drives out a lot of high-cost services. The emergency department is not the place you want to have a continuity of care. Population health, at scale, we've had health plans for well over 30 years in Oregon and Washington. We have about 2 million covered lives. We do everything from large commercial groups like Nike and Tel. We support, we actually provide Medicaid services to the state, small group market, individual market, et cetera. We also launched in Washington, D.C., incorporated a company called ION, taking 175 years worth of experience in care management, utilization, and processes, and created a consulting arm for Providence that now has contracts in multiple states working with Medicaid programs for how to improve care and systems of care. Patient experience, super important. This is not about the awards, but once again, it's about how do you work with the community to improve the services and your clinicians. And I gave an example of that in terms of the women's and health services, but it's really, and then scaling across. We actually have a partnership in this state between Alaska, Washington, and Oregon that shares all the clinical data and outcomes between our 3 states to improve healthcare, and we learn from each other in that. So that's another example that drives improvement for all the hospitals within this state. Innovate at the ends of the value chain. This is what Amazon did to disrupt the publishing chain. They basically took the authors and readers, eliminated, this slide didn't transmit, but they, through self-publishing, e-commerce, and Kindle, eliminated the components in the middle, put the authors and readers together for self-publishing. So what we're doing as part of our transition is how do we put clinicians and caregivers next to patient, and how do we disrupt the component in between and eliminate the waste and the non-value components so that we continue to transition to healthcare. Our digital journey, and moving the needle here in these elements which are replicated here, but this is our digital portfolio. We hired in Aaron Martin out of Amazon, who led the Kindle project, and he started our transformation into digital. We now have about 20 products that we've developed and are scaling nationally, and relationships with some of the largest IT companies in the world. In fact, 2 months ago, I think it was, that we announced a partnership with Microsoft, and Nadella, who's their CEO, in terms of announced that Providence, he believed, is one of the most transformative healthcare organizations in the country and wanted to partner with us. So we have a strategic partnership, and in Seattle, we're creating a hospital and ambulatory care center of the future to learn from. And we have people involved in that project throughout our system. Ella Goss, our CEO here at Providence, Alaska Medical Center, is involved in that transformation project down in Seattle. Those learnings will be taken out throughout the 7 states in which we serve. It's all about simplifying care, better serving Medicaid, making caregiver easier in health streams. Oops. This is our digital model. So what we do is we define the problem. And so it might be missed appointment or no-show appointments within Medicaid. We size and prioritize that. We look at who does this as the best in best in class, or we build it, or we buy it within the industry. We created Avia, which is a healthcare accelerator, which is 6 systems came together. If you can think of it like a Shark Tank, of where we take a product, and breaking into healthcare typically takes years. So we're doing this as short cycles of innovation. An example of that, which I'll get into in a moment, is Thistle, where we scaled that within a year. Literally, we did a pilot within 6 hospitals, took it up to 14 hospitals, and now we are nationally taking that within both our system and to other providers. So on the bottom, binary fountain is an example, best of breed. Social sentiment analysis for clinician offices gives real-time feedback in terms of what people in the community are saying about that provider and that practice, so they can improve the patient experience. Big tech partners, I talked about that. Xealth is an application that is one that actually is tied in with our electronic medical record. It looks at what is the best support application that the patient needs and then prescribes that. And it goes through our provider portal. Down on the right side there, you see this company name of Thistle. And Thistle actually is an automated engagement platform for a care process. So say you had an orthopedic procedure or a CV surgery, this is subscribed to the patient, and it basically helps the patients keep compliant with their protocol and know actually what is going on. Our 6-month pilot result, which I talked about, which we scaled from 6 hospitals to 14%, absolutely amazing outcomes. This was a spinal surgery one. 16.5% reduction overall complications from spinal surgery, 5% length of stay reduction, almost a 23% reduction in appointment cancellation. Satisfaction rates went up, reduction in patient calls to the clinic because they knew what was happening, and a 29% reduction in no-show rate and cancellation. So use of technology enhancers for different patient populations, and especially I think this one is important in Medicaid populations because often people need a lot more augmentation in terms of that. Reducing cost and affordability, you can learn about Providence Express Care out there. We're actually launching this by the end of the year. We partnered with the Public Education Health Trust. This was something that they asked for. How could we create better affordability and better access to care in advance of going to the emergency department as an option? So this is something that we've had in our system in the greater Providence for years. We'll have 5 locations, and we're partnering with some provider groups for oversight of this in the community. But 5 locations between South Anchorage and Eagle River. Concurrently launching is our virtual app. This has been around for a long time. It's great. That will be open effective next week, 12 hours a day, 7 days a week. What you're able to see in these are the 100 top diagnoses that you should not be going to an emergency department for. You're going to know the exact price of that, and it's tied in with your electronic medical record. If you're not part of Providence, that information will be sent to your physician. So it's really about avoiding expensive emergency department usage and responding to some partners in the community that asked us to put this in place. Civica RX. We joined with 5 other healthcare systems to create a generic drug manufacturing company. We just launched, publicly announced today, our first product, which is vancomycin. And this is to reduce cost of healthcare because of the high cost of drugs across this country. Last one is caregiver well-being. I'm running short here. It's really important that we work with our caregivers at the absolute best environment that I talked about. We're doing many programs and services to address that in terms of caregiver burnout. We routinely survey our employees, working on timely information so everybody knows what's going on. But bringing this together, it's reimagining our operating model. How do we define a better value chain, connecting with our communities in new and different ways, and making sure that we're always collaborating and partnering, and then rebuilding the organization from the ground up, from being an acute care organization to one that's a system of care, so that we can serve the population better with the underlying principles of the quadruple aim. So, thank you.
Good stuff. Yeah, thanks, Preston. I'm going to go sit down.
Sure.
And it's a little bit of an audible because I said I don't know that we'll have time for audience questions, but if you all have a question, don't be shy. I'd be happy to get you a microphone. So raise your hand if you have something you want to ask. I'm curious. Providence, the population health piece is central to all of this stuff. A plan is an important piece of that. A risk-bearing entity, a care coordinating effort. Providence has a health plan. It has strong partnerships with plans here in the market. But do you think, I know it's not required that Providence be a health plan in order to accomplish some of this stuff, but do you think that the value proposition of a unified health plan and provider in Alaska, justifies introducing Providence as a health plan in this market?
We would always sooner, as I said about, is collaborate and partner where we can. And we have strong partnerships with Primera and others in the community. And I think for us, one of our goals overall is Providence, and I'll say this because it's public, and Rod Hochman talks about this, and Mike Butler, who's our president of operations, but we fully intend to, as quickly as possible, to get to a 30% share premium wherever we serve over time. So that's how do we create partnerships and unique opportunities with plans so that we have shared savings and are doing the right thing. I truly believe that managed care models incent the right things for everyone working together, but it's important that we have in terms of the physician community, have the right infrastructure to support them. This is very costly to do it right, and so we have to make the investments in those things like care navigation. I know that up in Matsu, they did their high utilization management program, which had awesome results. We've seen that in many other markets. It's emulated in the CMS demonstration project. But how do we work with health plans to create that system of care and then reward everyone economically while at the same time dropping the cost of care by eliminating the waste? And when you do that model, you'll get there.
So when you say 30% share of the premium, is that 30% of the premium dollar?
No, in terms of the care that we provide, that more and more of what we do is under a managed care scenario versus fee-for-service in all our markets.
So a target of 30% managed care.
Correct.
Delivery or delivery that's funded through managed care.
It's kind of the first step in that.
Yeah.
Because that's really the best way to serve a population.
Good. I know one of the things you had talked about is the idea of, we talked about this ahead of time, caring or financing care delivery, particularly in rural areas, at a community capitation level or a population, an all-payer fixed revenue level for a community, meaning like in places like Pennsylvania and Maryland and in Oregon, where a community has a fixed amount of money and they have to figure out how to spend it within the delivery system to meet the needs of the community there. Share some thoughts on, even though they might be preliminary, about how you think Providence might work within that community capitation level, particularly in the rural areas.
So I've been trying really hard to get out and learn the state, and you can't do that without actually experiencing the state. So one of the first things I did to experience the state when I first came up here is the day after Christmas, I drove up the Alcan from Seattle. So I got to see, get a little bit of breath in terms of how big this place is. And I've been out to the North Slope, I've been out to Bethel, I've been out to all our communities we serve, and the goal is to get around and see and learn from folks in terms of what the real environment is. And we are almost like two states. In terms of the Anchorage-Matsu area, it's very much like I experienced down in Washington State, an urban area, and some of those principles will work. We have to make them Alaskan, in terms of some of the different factors. But for the most part, a lot of the learnings from lower 48 will work. Rural Alaska is a much different animal. I mean, 70% of the state you can't get to by road. So the cost of care is very expensive, and how do we keep providers in the community? In thinking about different national models, one of those is a global budget model, and I think might really work. And I actually would like to have some dialogue with the state and some of the cities around that we serve that might work as a model, because if you actually think about the cost expended for healthcare within a community, it's pretty impressive. And if you step back in those, often most of our small hospitals are very few beds. They have an emergency department and a clinic and then skilled nursing type facilities. And they're worried, they work on just a no margin essentially at all. And they're constantly worried about that next patient that comes in the door. But what happens if you take that away and actually give them a set stream of income that they can redesign and really invest in what is the clinical practice, the environment, keep people out of the hospital, use virtual models also to support the care locally and keep it locally. I think that we could have a much better model of care there. People wouldn't have to work on it. The community would work on the right things and we would have better outcomes. And so I think that's a model that I want to test in a couple of our smaller markets.
Not to seem too random, but my sort of concluding comment would be Madeleine Albright, the former Secretary of State, wrote this book and used to talk about the United States as being the indispensable nation in the world, that nothing can really happen without the United States' participation or acquiescence or leadership. And whether, I know many people have different opinions about Providence throughout the state because of the long history here, but everyone I think would agree that Providence is the indispensable institution in Alaska healthcare. In other words, Alaskans are all depending on you, whether they like it or not, you at Providence, to be a leader if folks are going to move forward. So thanks for making time to be with us here today, and thanks for sticking around and getting buttonholed in corners by folks and spending some time in conversation. Okay. Let's give them a round of applause.
I'd be happy to answer any questions folks have.
Thank you,
Thank you so much for letting me speak today.
Thank you, sir. Appreciate it.